the other one first.
This one? This one?
Yeah. Thank you.
Just click on right here.
Yeah.
Good afternoon. Appreciate the invitation to participate in this conference. And for this plenary talk, I will focus on non-invasive neuroimaging techniques and give examples of their contributions to diagnosis, to remediation, and prognosis. I will cover several modalities of brain imaging, and the studies that I'll mention as examples will include traumatic brain injury and stroke. So we'll begin with some of the structural imaging applications for diagnosis and for prognosis. The CT scan and magnetic resonance imaging MRI have greatly contributed to classification of traumatic brain injury. And some of the prognostic applications that we'll cover include the ventricle-brain ratio, which is a very simple and somewhat dated approach, but it has been in the literature, and it's very easy to do. We'll also consider brain region volumes and voxel-based morphometry. The classification of traumatic brain injury based on the Glasgow Coma Scale, as you have just heard, assumes a continuum that's reflected by the severity of impairment of consciousness. And when we first consider the Glasgow Coma Scale and appreciate that it's based on observable responses, and it's clearly an improvement over what existed previously. In this paper, which was a report of a workshop held at the National Institute of Health, the problems with the Glasgow Coma Scale were reviewed, and some of these pertain to our topic this afternoon. The heterogeneity in the anatomic lesions and pathophysiology. This means that we can have several patients with the same Glasgow Coma Scale score, but they have much different kinds of brain injury when we look at their CT scan. So they really are not equivalent, and anyone who reads literature on outcome or is engaged in the rehabilitation of patients with moderate to severe traumatic brain injury is impressed with the variation in their recovery, even though they may have similar Glasgow Coma Scale scores. There are other issues that also complicate administration of the Glasgow Coma Scale, but for our purposes this afternoon, it's the heterogeneity in the anatomic lesions. This is brought out pretty well here. Oh. These are these CT scans are from 6 different patients. They all had the same Glasgow Coma Scale score. So the CT scan on the day of injury shows an epidural hematoma. This type of hematoma, if it is surgically evacuated quickly, is compatible with an excellent recovery. Patients within days may show marked improvement, provided that the epidural hematoma is removed, is drained quickly. Otherwise, there can be expansion of the hematoma and increased intracranial pressure, as you just heard. In this case, the lesion, a hemorrhagic contusion, may not expand, and over time, typically these spontaneously resolve. So it's a much different type of injury in terms of the clinical management. Here, we don't see this very well, but this is a patient who was thought to have diffuse axonal injury. This is on the CT scan, the indicators of diffuse axonal injury are generally thought to be the compression of the ventricles because there is brain swelling. So these compress the ventricles. The ventricles may appear only as a slit, or they may be completely obscured. And when this diagnosis is made, there is no mass lesion, no large lesion. However, the name diffuse axonal injury implies that there's injury to the white matter tracts. However, this cannot be seen on a CT scan, so it's a limitation. But these patients have a much different course of recovery than, let's say, again, the patient with the epidural hematoma. And there may be increased intracranial pressure in this patient because of the brain swelling. And so the intervention is to control brain swelling. Here, this is a patient, a CT scan of a patient who had a subdural hematoma. This is a especially lethal kind of hematoma. It is generally seen only with severe injuries, with the exception of older adults who may develop a subdural with an apparently mild injury. Again, there's often an indication for surgical intervention, and these patients often will have a worse outcome than the patients with epidural hematomas. And often there's more distortion of the brain and more of a shift in the direction opposite to where the hematoma is. So again, at one point in time, the Glasgow Coma Scale score might be the same as the patient with epidural, but these patients tend to have a much worse outcome. Then there are patients whose primary findings are subarachnoid hemorrhage or intraventricular hemorrhage. Finally, this patient who has diffuse brain swelling, but doesn't carry the diagnosis of diffuse axonal injury. On MRI, one additional source of information might be the appearance of very tiny hemorrhages, and these can be seen in patients who are classified as having diffuse axonal injury. But again, the inference of diffuse axonal injury it's indirect. One cannot directly observe the injury to the white matter tracts with this type of imaging. But the main point here is the heterogeneity, which can be appreciated much better with imaging and is simply lost using only a Glasgow Coma Scale. And the different types of injuries have different prognoses, even though they may have similar impairment of consciousness. So using the volumetric magnetic resonance imaging, this in addition to the ventricle-brain ratio, does carry prognostic information, especially in regard to the quality of the recovery. This isn't prognosis in regard to survival, the way that the initial CT scan is. So with the ventricle-brain ratio, I think, yeah, here we see how this is calculated. So basically, the way this used to be done was with CT scans is we would work with the actual hard copy of the CT scan, and it would we would see the tracings and actually use an instrument called a planimeter to trace and measure the size of these ventricles, and then express that as a numerator, and the entire area on a slice was the denominator. Now this could be calculated by computers and much more accurately. But what we see here going from left to right is increasing size of the ventricle-brain ratio, indicating that the relative to the parenchyma of the brain, the area or volume of the ventricles is taking up more, accounting for a higher percent. So what do you suppose contributes to this? What is the basis for these increasing prominence of the ventricles in relation to the brain parenchyma? In most cases, it tends to be degeneration over time, especially of the periventricular white matter. This is thought to be the primary mechanism. There are exceptions. There may be individuals with hydrocephalus, but the most common mechanism is this degeneration of the white matter. And there is a there's a moderate to strong correlation between the size of the ventricle-brain ratio and overall cognitive recovery. There are a number of studies that have shown that. Another useful technique is to actually measure the brain region volumes. And there's some evidence that this may be more prognostic than measuring the size of lesions. Here is a study that my collaborators and I published in the Journal of Neurotrauma. This particular study was concerned with children who had sustained moderate to severe traumatic brain injury, and we measured the brain region volumes. In order to accomplish this, a number of the investigators in our lab worked with Aaron Bigler in Utah and developed a template for specific brain regions. So the template included prefrontal regions, including the inferior mesial prefrontal region, the superior mesial, and the lateral prefrontal region. And the temporal regions were measured, as well as parietal and occipital. And the prefrontal region was, the mesial prefrontal region was further separated into orbital frontal because of the importance of this region for cognitive and behavioral changes. So we wanted to obtain specific volumes. In developing these templates, Lisa Wild, a neuropsychologist who had worked with Aaron Bigler, and Jill Hunter, she is a neuroradiologist, were able to show that there was very good inter-rater reliability in measuring each of these regions. So what was found prognostically was that the percent of preserved frontal temporal tissue was strongly related to the Glasgow Outcome Scale, which you heard about just a little while ago. So here is the percent of frontal temporal tissue represented. This is a box plot. The horizontal line represents the median. This is the 75th percentile, 25th percentile, and these are the extreme sort of scores. So these are healthy children who had an MRI, and we could see that they have a higher percent of preserved frontal temporal tissue, and this is calculated by using the volume of the tissue as the numerator, and the denominator is the volume of the tissue plus the volume of the cerebrospinal fluid. Because as you saw with the ventricle-brain ratio, there's a tendency in more severe injuries for the CSF to take up more space. So what we see among the children who sustained moderate to severe traumatic brain injury is a strong relationship between the quality of the outcome and the percent of preserved frontal temporal tissue. In contrast, the same analysis was done for more posterior tissue. So this was parietal, occipital regions, and there was very little relationship to the outcome on the Glasgow Outcome Scale. Now, had we measured other kinds of functions, perhaps visual attention or visual perceptive measures, we may well have seen a relationship, but on the Glasgow Outcome Scale, we didn't see any significant relationship to the percent of preserved posterior tissue. So this type of measurement can be done. There are a number of different software programs that are available, that commercially available, and now there are even freeware which will do this with not a great deal of training, but it is important that to have good inter-rater reliability in identifying these regions. So this was the statistic for the preserved frontotemporal tissue. And you could see the chi-square was significant, posterior volume was not. Another approach that is also, we think, has a lot of potential is called voxel-based morphometry. And here, the brain imaging data can be broken down into voxels. When we look at an image, it's comprised of voxels. And we could compare two different groups and ask the question, for which brain regions do these two groups differ the most? And without having any particular hypothesis. So this approach is used in various neurological disorders as an initial approach to see which brain regions have been primarily affected. But voxel-based morphometry can also be used to identify which brain regions change the most from one time to the next. For example, if we suspect there's some degenerative changes going on, but we don't know which brain regions are primarily affected. This takes enormous computer resources as compared to some of the other kinds of analyses, but there is relatively new software that can do this pretty efficiently. Here is an example. This was done by a graduate student of Dr. Bigler's, who was working in our lab. And what she did was to compare the MRI of children who were several months following moderate to severe TBI to the MRI of children who had sustained a injury to other parts of their body. Usually this would have been an arm or a leg, but they had no injury to the brain. So they were, neurologically, they were intact. And what we see here is represented by red and especially by the yellow areas are regions that differed the most in terms of cortical thickness. So there was cortical thinning in the children who had sustained moderate to severe traumatic brain injury. And so this shows up very well in prefrontal cortex, to some degree in temporal regions. And it is also related to the quality of the recovery. This was published also in the Journal of Neurotrauma just within the past year. The author's name is Merkley, and we talked a little while ago about diffuse axonal injury using CT and MRI, and as we mentioned, that it's problematic to appreciate the axonal injury using a CT scan or even using MRI. There is some evidence that a sequence on MRI, which is called T2 star, can visualize very small hemorrhagic lesions that are thought to be indicative of diffuse axonal injury. Positron emission tomography is an invasive form of brain imaging, so we're not going to spend much time discussing it, and it's not widely available, but it can show regions of the brain that have very below normal metabolism, and this is thought to perhaps be an indication of diffuse brain injury, even when there are no visible brain lesions on a CT scan. A recently developed non-invasive technique that can be done on a conventional MRI scanner is diffusion tensor imaging. And this is quite sensitive, and I'll show you some examples of it. And it evaluates the microstructure of white matter tracts. In regard to mild traumatic brain injury, as I think everyone here is aware, these injuries account for the great majority of all traumatic brain injury. And although the majority of these patients recover extremely well, there are some exceptions and who take longer, and there may be occasional patients with complicated outcomes and who have persistent symptoms. And yet, conventional MRI is completely normal in these patients. So it may be that other kinds of imaging may be informative. So susceptibility-weighted imaging is is used currently for research applications. It isn't widely used for traumatic brain injury. However, there is evidence that susceptibility-weighted imaging can show very small hemorrhagic lesions that are in the vicinity of white matter tracts and are thought to be indicative of axonal injury. So here we see different imaging that was done very shortly after this 12-year-old child who was studied at our center following a skateboard accident. This was 4 days after the injury. The Glasgow Coma Scale score at the scene of the injury was, and at the time of admission to the hospital, was 15. So there was normal consciousness. The CT scan did not show any lesions. Here we see a gradient echo MRI, not too informative. But here we see susceptibility weighted imaging and these a number of these very small hemorrhagic lesions that were not seen on the conventional imaging. Karen Tong at Loma Linda Medical School in California has reported that susceptibility weighted imaging is quite sensitive to the severity of impaired consciousness and is prognostic of recovery. Our interest at this point in using this technique is in a project on mild TBI. And we do not yet know whether this is typical or whether we just happen to study a very unusual injury. But even a single patient with this kind of finding is provocative, so we think it's a technique that may prove to be useful. In patients who do not have lesions on the CT scan acutely after the injury, and don't have large lesions on MRI, it is generally presumed that diffuse axonal injury is the primary mechanism of injury. And the evidence for that comes partly from animal models. For example, work done in the 1980s with monkeys in which they were subjected to their sudden acceleration, deceleration without any impact to the head and without causing large mass lesions. And yet, with these injuries, it was shown that there was a gradient of axonal injury. In some cases, the axon was damaged. In others, it was completely torn. And yet, on conventional imaging, we would not see any of this because this is at a microscopic level. As I mentioned, positron emission tomography can show areas of the brain which have below normal metabolism. And this has been demonstrated in patients who were considered to have diffuse traumatic brain injury because their CT and their MRI showed no lesions, and yet they had been in coma. So there was a study done in Paris by Fontaine et al., which was published in Neurology, and they studied patients approximately 1 year after sustaining severe diffuse traumatic brain injury. And they were mainly interested in executive functions. And these were 13 adults. Excuse me, they ranged from 1 to 12 months after severe diffuse traumatic brain injury. And what they found was that the rate of glucose metabolism at rest was reduced in patients, and it was especially the reduction in hypometabolism was especially marked in prefrontal cortex. And at rest, the degree of hypometabolism was related to executive functions, including verbal fluency, an attentional task, card sorting. And this relation was to the prefrontal hypometabolism was significant, and as well as for the anterior cingulate, which is thought to play a role in monitoring performance. There was also some relation to memory, particularly for the left prefrontal cortex and the anterior cingulate. In addition, the prefrontal hypometabolism was related to a clinical measure of executive dysfunction in everyday life. Now we'll consider diffusion tensor imaging, which is a non-invasive measure of the microstructure of the white matter microstructure. The diffusion tensor imaging measures the diffusion of water. And in this example, water is diffusing in every direction. And this is represented by what we refer to as fractional anisotropy. And here, the fractional anisotropy refers to the tendency of water to diffuse parallel to the axis of white matter tracks. But when this FA is equal to 0, it's diffusing in all directions. Here we see a larger value of the FA because this reflects that the water is diffusing in a restricted manner parallel to the white matter tracks. These walls of the white matter track ensure that the water is diffusing in parallel. However, if there is white matter injury and there is compromise of the walls of the white matter tract, the FA will be reduced. And there are other measures that we can obtain from diffusion tensor imaging. The FA is the measure that's most widely used. And this is also reduced in disease, in neurological disease that attacks the white matter, namely multiple sclerosis. So here we see an example of diffusion tensor imaging. The green represents white matter fibers in the anterior to posterior direction. The red represents the left to right white matter fibers, and the blue represents the direction of dorsal and ventral, or what's sometimes referred to as the z-axis. And these fibers, their density is reduced by traumatic brain injury. And we've seen cases in which there are some subtle reductions, and yet the Glasgow Coma Scale is only slightly, indicates only mild impairment of consciousness. I should also point out that this is highly sensitive to to age. If one is performing diffusion tensor imaging in children, with development, the density of these fibers will increase. So if you're studying children using diffusion tensor imaging, the comparison group has to be well matched on age. On the right here, you'll notice that this is a child that sustained an orthopedic injury, no injury to the brain. And you can appreciate the representation here of the anterior to posterior white matter tracts, which provide connectivity between prefrontal cortex and posterior regions. Here, for comparison, is a child of equal age to the control who sustained severe traumatic brain injury. And you can see that there's that the functionality of the white matter tracts has been compromised. And we and others have reported relationships between the changes in these tracts and cognitive function. A finding that's especially provocative are some recent studies using diffusion tensor imaging in mild traumatic brain injury. Patients who have normal CT and typically normal or very mild findings on MRI. So we published the study. Lisa Wild was the first author in Neurology just about 1 year ago. This was a preliminary study of 10 adolescents who sustained mild TBI and 10 age and gender matched adolescents who were healthy, had no injuries. In the 10 adolescents with mild TBI, they all had a GCS score of 15, and they had brief loss of consciousness. They were imaged between 1 and 6 days after injury, and they were treated in the emergency room. Only one of these 10 adolescents had a very subtle finding on magnetic resonance imaging, but again, they all had normal CT scans. So what we found, and here these black circles represent the FA of the children with traumatic brain injury, you can see that their FA is higher than the controls. So you may think that I'm contradicting myself because I mentioned that the FA goes down with severe white matter injury or even moderate white matter injury. But we see that the FA is higher. And what we think this represents is what is referred to as cytotoxic edema. So there's an increased water content reflected by this increase in FA. And we do not believe this represents permanent structural changes in the white matter. And what is also interesting is we see this increase in the FA is related to the severity of post-concussion symptoms. This was measured using the Rivermead scale of post-concussion symptoms. So as the adolescents complained of more severe symptoms, they had higher FA. And we also saw this on a measure of general emotional distress, the brief symptom inventory. And this is just a few days after, within the first 4 days after injury, also related to the FA. There are now in the literature at least 2 other studies that reported exactly the same finding. So you might ask, well, what happens if we repeat the diffusion tensor imaging in a month after the injury, or 3, 6 months? Does the FA go down? Does it become normal, or does it go below normal? No one knows. This is one of the issues that we're taking up. So the last imaging modality I'll describe briefly is the functional MRI. It is non-invasive. It has good spatial resolution, but it's challenging to do in patients with traumatic brain injury. And there's an issue about the difficulty of the task that the patients are asked to perform. Often the patients cannot perform tasks as well as healthy persons, so making comparisons is difficult. And the fMRI is quite sensitive to some psychotropic drugs. So in mild TBI, there was a very provocative study published by Tom McAllister at Dartmouth Medical School. This was in neurology. He studied 12 adults just a few days after a mild TBI using a measure of working memory. And he found that there was a difference in the frontal parietal activation while the patients performed working memory as compared to healthy control subjects. But it was interesting, here we see the activation for controls versus mild TBI patients. So under a relatively easy condition of the working memory, when there was a very light memory load, the controls showed more activation than the mild TBI patients. However, when the memory load was increased, the mild TBI patients showed more activation than the controls. They went on to do another study which also showed differences in activation. Interestingly, these patients, when they were given neuropsychological tests, performed just as well as the control group, but they did have post-concussion symptoms. They complained of headaches, dizziness, fatigue, and so forth. So quite an interesting study, but we don't really know what the mechanism is. McAllister hypothesized maybe this had to do with alteration in neurotransmitters, but no one really knows, and no one knows how it might change over time. So another interesting question that I was asked to address is about prognosis and whether fMRI can be useful in predicting response to rehabilitation. Potentially, it might be useful. There's one group of investigators have looked at this, Strangman and his collaborators. They asked whether fMRI could predict response to memory rehabilitation. So they evaluated memory strategies for word lists that included words that could be categorized, like different fruits. Healthy subjects, when you give them a list of words that can be categorized, tend to cluster the words in their recall. So they'll do the fruits, then they'll do the vegetables, and so forth. But patients with severe TBI tend not to cluster words by category to the same degree as healthy people. So they measured the brain activation for 3 kinds of lists. One type of list were unrelated words. These were not from specific categories. Then they had lists of words that could be categorized, but the patient was not instructed to use this clustering. The third condition were words that could be categorized, and the patients were instructed to use a semantic clustering strategy. So what was found was that in those patients who showed left dorsal prefrontal activation to the directed use of clustering, showed gains on memory tests after 12 sessions of memory training. And for example, one of the outcome measures was a Rivermead memory test. So doing the fMRI before the memory training predicted response to the memory training, especially when it was used, when they looked at the activation to the clustering of words that were in different categories. This is just one study. Whether this can be extrapolated to other kinds of rehabilitation techniques, we don't know. But here's the area, the left dorsolateral prefrontal cortex. So And the finding was it was U-shaped. So if the patients showed increased activation when they were directed to use clustering, if they showed a moderate degree of activation, this predicted a good response to memory training. If they showed no activation or they showed a very high level of activation, this was not predictive of a good response. Another area that was somewhat predictive was the angular gyrus. So what are some of the implications of this study? Perhaps a similar approach using fMRI could be used for executive function training, maybe with tasks such as goal management or switching, perhaps even in social cognitive networks. fMRI could be used to predict response to psychosocial kinds of interventions. To my knowledge, I haven't seen any studies about this, but it occurred to me in preparing this talk. How much time should I take?
Not much.
I know I'm holding up lunch. Because I can cover the rest in my workshop, if that would be.
People can tolerate if they go another 10 minutes.
A few minutes? Okay. All righty. So,
Sorry, I would like to have a conversation, so please go faster.
quickly. Okay. I'll be very brief here. I'll make just a couple of points about functional imaging and stroke, just to explain how it's different from traumatic brain injury. With stroke, often the question is the reorganization of function that depended on the hemisphere that sustained the stroke, at least in unilateral stroke. And the functional imaging can be used to show change in the pattern of activation, for example, with motor function. So if the motor cortex of the left hemisphere has been damaged by a left hemisphere stroke, what is typically seen as the patient recovers is increased activation of the opposite hemisphere. So this would be the right motor cortex. But with rehabilitation and recovery over time, what is seen in patients who eventually show a fairly good recovery of their motor function is that the motor cortex of the damaged hemisphere shows increased activation over time. So this is somewhat different than what people believed maybe 20, 30 years ago. It was thought that the healthy hemisphere would become would take up more of the function and compensate for the hemisphere that had the stroke. But with the application of functional imaging, what has been seen is that the increased participation of the healthy hemisphere is transient. It compensates for a while. But eventually, in those patients who show good recovery, the participation returns to the damaged hemisphere. And this is associated with rehabilitation. So that's really the main point I want to make about stroke, because it's much different type of application of the functional imaging, and so I won't belabor it. But one interesting finding is that this increased activation has been shown also with language to be related to increased improvement of language comprehension. And this was done at the University of in Germany. It was published in Brain in 1999, and I think it's quite an interesting study showing that use-dependent neuroplasticity occurs with language training as well as motor training. And there's now some evidence that this may also occur with training for visual neglect after stroke. So, and I just very briefly mentioned transcranial magnetic stimulation also is now having some therapeutic applications, and the reason is that the area that's impacted by the stroke tends to be over-inhibited by the contralateral region of the healthy hemisphere. So transcranial magnetic stimulation can inhibit the healthy hemisphere and thus reduce the inhibition of the damaged hemisphere. So this is a promising non-invasive technique as well. And this just explains it. Here we see the hemisphere with this infarction, and the inhibition from the healthy hemisphere is much greater than the inhibition going toward the healthy hemisphere. So if we use transcranial magnetic stimulation of the healthy hemisphere, we can inhibit it and reduce this inhibition of the damaged hemisphere. And there are studies suggesting that this can facilitate recovery as well. So I think this just summarizes what we've talked about, and it may well be that imaging can also be used to evaluate the effects of pharmacologic treatment following brain injury or stroke. And I think I'll conclude here. There's some implications for rehabilitation. So with lateralized deficits, a training approach can enhance reorganization. fMRI and DTI can indicate alterations in neural networks that are associated with cognitive changes after TBI. And we see that fMRI may be useful in predicting response to rehabilitative interventions. Subtle changes in the circuitry may be related to neurotransmitter imbalances following mild TBI, and perhaps this can be treated. And there's a need for combined treatment and imaging studies. Thank you.
Thank you very much for your excellent talk. The paper is open for discussion. We have time for 1 or 2 questions. Please go ahead.
Thank you very much. Have your data on the mild head injury in children led you to some recommendations regarding handling the post-concussion syndrome in children that is so common? I mean, regarding how we face it and maybe treating the symptoms.
I think one of the, from my point of view, there's a couple of issues. And I would refer you to a paper we published 1 year ago in the Journal of Neurosurgery. This paper compared at 1 year after injury the cognitive recovery in children who had mild impairment of consciousness with CT scans indicating contusions and other kinds of changes in the brain. even though they had mild impairment of consciousness. Their functioning at 1 year was worse than children who had the same GCS scores but had normal CT scans. One reason I'm mentioning this to you is in the United States now, it is not routine to do a CT scan in all children with mild injuries. So one point is that we're overlooking children that actually have some brain pathology and may not have strictly a mild injury. They may have an injury that we would argue is worse than, probably not consider it just a mild injury. But assuming it is, you're assuming that the injury is mild. So my suggestion is, first, there's a need for education of the child so they understand post-concussion symptoms and they realize that they may have to make some temporary changes. For example, they may need to rest a little bit more for a while. If they have an examination a few days after their injury, they should be excused from it. That they may be feeling tired for a couple of weeks, maybe even longer. They may fatigue more easily. They may have some headaches. But I think education goes a long way, and this is also very important for the family. There was a study done in Philadelphia of children who had extremely mild TBI. This was in the days when we referred to these as mild head injuries. And what was found is they did an interview with the child's mother on the day of the injury. These were children seen in the emergency room. They were examined, they had skull x-rays, and then they were discharged. They found that the level of anxiety of the child's mother was predictive of how frequently the child would be missing days from school in the month after the injury. It was also predictive of whether the child would be permitted to engage in recreational activities. It was related to the anxiety level of the child's mother. And typically in emergency rooms, I'm sure then and to some extent even today,